Good morning, everyone. It is such a pleasure and honor to be back with you. My name is Kevin Ann Huckshorn. Many of you probably know me because I've been lucky enough to do a number of years of work in Massachusetts, and I hold your state in great esteem for the work that you have done in the past on seclusion and restraint reduction, both in the adult and the child adolescent areas. I want to mention and just second what Janice has said. What has happened in Massachusetts is very similar to what's happened in many other states in terms of COVID creating just a integrated collection of challenges that have really almost put us into a kind of survival mode. And when that happens, sometimes things get dropped. And one of the biggest issues with COVID was the incredible workforce reduction, and then the need to hire, just about anybody we could just to get our services to continue to operate. And in many cases, training dropped off, onboarding of new staff got greatly restricted and shortened. And so we are, as Janice said, going back to the beginning. We're starting over, as is many other states, and it's more important than ever because, and I'll just be really blunt, people are dying, and in addition to people dying, people are getting hurt, and those people are often both the folks that we serve and the staff that we're asking to serve them. Another important piece here is that the six core, the reduction of seclusion restraint, and frankly, the six core strategies as the only evidence-based practice that we know of at this point that's in existence has expanded to the Department of Corrections across the country, schools and education, departments of juvenile justice, and emergency rooms. In some states that happened to some degree 20 years ago, but in many states, this work was mostly focused on behavioral health. So it's really critical that we really go back to the beginning and start over. It's also really important for you as a behavioral health professional, regardless of your role, to understand that the competencies that are required to be an expert in preventing conflict and violence, they're not really optional competencies for anybody that works in behavioral health. They're mandatory competencies at this point. And I can say that with pretty assuredly because the courts are holding us responsible. And when a tragedy happened, like just happened here in North Carolina, where I am, people are being charged with pretty serious charges if they were not competent. So I'm really thrilled to know the numbers of people that have joined this morning. And I am going to start out this morning with an overview of the six core strategies, mostly just to remind some and introduce to others that are new to this work. So the six core strategies, I think I went too far ahead. Yep, sorry. The six core strategies were developed as in response to a number of kind of a constellation of things that happened in this country starting back in 1998. In 1998, the Hartford Courant, which was a relatively small newspaper in Hartford, Connecticut, learned of the death of a child. His name was Andrew McLean. He was 11 years old. He weighed about 90 pounds. He was having difficulty at school and at home. And so he was admitted to a residential program in Hartford, Connecticut. And the paper learned that he had died there. And the editor of the paper was shocked and started to ask some questions, like how could a young person who's having trouble at home and school be admitted to a healthcare setting, and die. Well, of course, the paper got the usual response: confidential, under investigation. We can't give you any information. So the Hartford Courant editor said, well, that's not good enough for me. I don't understand what this thing is called restraint. This sounds very odd to me. So he, in response, sent out 4 investigative reporters in 1998, and they traveled the country for about 8 months. And they spoke to hundreds of people. They talked to people in Washington, D.C., policy people. They talked to SAMHSA. They talked to all the national organizations like the American Association for Psychology, Psychiatry, Psychiatric Nursing. They spoke to the Center for Medicare and Medicaid. They basically talked to Joint Commission and CARF. They also interviewed a number of family members who had lost children or who had children be hurt or adults be hurt in behavioral health services. They spoke to hospital directors. They spoke to associations like the National Association for Mental Illness and other national associations like the National Association of State Mental Health Program Directors, NASADAD. They basically talked to everyone they could find to find out about this process or strategy or intervention called restraint. And they came back at the end of 1998 and they published a series of articles in their paper. And they titled those articles Deadly Restraint and the Use of Deadly Restraint in the United States of America. And they talked about the fact that what they had found was that restraint was being used all over the country. It was not being tracked or monitored. It was not being reported. If someone was hurt or worse, killed, that was not reported. There was no database on it. There was no real research that had ever been done on the use of seclusion and restraint. And it was, like a 1,000-year-old practice. They identified that in some countries like France and others, there had been attempts to eliminate the use of restraint, but those had not lasted very long. They also interviewed many of our colleagues who said that we need to use restraint, that's what keeps us safe. So they wrote these articles up, and within 3 months, the United States Congress was holding hearings on the use of restraint because this had such an enormous impact in the country. And it was quite surprising, guys, because while restraint is indeed a huge issue and a dangerous practice, in the scheme of life, if you will, behavioral health and restraint is has a small footprint in terms of what's going on in the entire country. So for this to get to Congress that quickly was a real surprise to all of us. So Congress held hearings, and they subpoenaed people, and people came voluntarily, and they listened to consumers, they listened to family members, they listened to professionals like all of us, and they got the same reports from some people, how dangerous restraint was, how people had died. The Harvard School of Risk Analysis estimated that 1 to 4 deaths was happening every week in this country proximal to the use of restraint. But they also heard from our colleagues, some of our colleagues who said, we have to use restraint. We've been using it for decades. The Hartford Courant exaggerated the issue, go away, basically. So Congress then dispatched a number of investigators from the United States Governmental Accountability Office. And I had no idea what that office was when we first learned about it. But the United States Governmental Accountability Office is kind of the watchdog for government. And it's kind of similar to, for instance, internal affairs for a police department. So they kind of watch and investigate what the government does. So Congress sent out a team from the U.S. Governmental Accountability Office. They went around the country and basically followed in the Hartford footsteps. And they came back at the end of 1999 and wrote a report, and all this is still online if anybody's interested, And they basically supported everything the Hartford Courant reporters had written. But one of the things they did that was so incredibly helpful was in their work, they also identified states and facilities that had on their own decided to reduce the use or even eliminate the use of restraint and seclusion all on their own. And for those of you who don't remember back in this early days, the internet was not like it is now. So there wasn't almost anything on the internet about seclusion and restraint. People didn't use the internet like they do now. Google was nothing like it is now. So there had been very little information about this work that these centers of excellence, if you will, had taken on. And one of those states was Pennsylvania. To be perfectly honest, one of those states was Massachusetts in terms of child adolescent. Pennsylvania had done this work with their 10 adult state hospitals. Massachusetts had already started their work for their child and adolescent residential programs and hospital programs. Florida, where I had just left that position in 1998. In 1998, we had undertaken the elimination of the use of restraint and seclusion at South Florida State Hospital because the state had mandated that we do that because people had been seriously injured and hurt. So the U.S. Governmental Accountability Office report basically combined all this information and gave us a really good starting point to start this work. Also in 1999, for the first time in 30 years, we had a Surgeon General's report on the state of behavioral health in the United States. And the Surgeon General's folks also talked about the need to reduce and in some cases even eliminate the use of seclusion and restraint because of the harm it did to the people we serve, families, and staff. As a result of those documents, the Centers for Medicare and Medicaid were then put under the gun by Congress to do something about it because the Centers for Medicare and Medicaid basically govern what happens in any kind of public sector healthcare setting that receives Medicaid or federal funding. So the Centers for Medicare and Medicaid got together and rapidly did an emergency interim rule on seclusion and restraint. And for those of you who were around back then, you'll kind of remember hearing about the 1 hour rule where a psychiatrist or a prescriber had to show up at the bedside of anybody put in seclusion and restraint within 1 hour. They also mandated some training differences and additions to staff coming on board to work in behavioral health and some documentation mandates. But again, back then we didn't know much about how to reduce the use of seclusion and restraint. So at the National Association of State Mental Health Program Directors, which is titled NASHPD in terms of their acronym, I had gone to work there as the director of the National Technical Assistance Center for State Mental Health Planning. So I was tasked to pull together an expert group to come to Washington and to brainstorm how we were going to help the field reduce the use of restraint and seclusion. And so Dr. Janice LaBelle, who mentioned, but was one of the founding faculty at this meeting. So was Beth Caldwell and a number of other people. There were probably 16 or 17 folks at the very beginning. And we got their names from the U.S. Governmental Accountability Office. So the 6 core strategies, if you're interested, is what we call a service to science evidence-based practice, because the knowledge came from the field. It didn't come from books. It didn't come from academia. It didn't come from some, clinical trial. It came from the field, from people who had actually done this work and been successful at it. In 2002, NASHPD wrote the first national policy statement on the importance of reducing the use of seclusion and restraint and why. About that time is also when the concept of trauma-informed care emerged in behavioral health. And obviously was extremely closely linked to the experience of people being restrained and secluded. CMS then changed their rules again, and had kept kind of updating them as new information came out. The New Freedom Commission, which was commissioned by President George Bush, was also published in 2003. And it also talked about not only the need to help people recover, but the importance of peer support and the importance of reducing the use of seclusion and restraint. So through that work with these subject matter experts in Washington over a period of a number of months, we had 3 focus group meetings. The 6-core strategy curriculum was developed. And that is because, and this is important, everybody that we spoke to at that time who had done this work and had successfully reduced the use of seclusion and restraint, and that includes child adolescent programs, nursing homes, emergency rooms, state public hospitals, private psychiatric facilities, and intellectual developmental disorder facilities. All of them that had been successful had basically done the same thing. And that's where the 6-core strategies emerged as we know them today. So in 2004, our partners, the Substance Abuse and Mental Health Services Administration, who basically fund our block grant, our state block grants, and who kind of lead us in the development of evidence-based practice and promising practices, they decided they wanted to spend the money to find out if the 6-core strategies was research-based. So the SAMHSA commissioned the Human Services Research Institute in Cambridge, Massachusetts, to develop and initiate a 8-state research project on the 6-core strategies. In those 8 states, there were 43 facilities, child, adolescent, adult, and public and private. And so they were all trained in the 6-core strategies. And then for a number of years afterward, were monitored and coached on implementation, and their data was collected by HSRI. At the end of the day, 28 of those 43 facilities completed that work. And just to let you know, the reason why all 43 did not continue, some of the hospitals closed. There was a very serious hurricane which kind of wiped out all the hospitals in Louisiana. There were also a couple facilities who ended up being decertified by CMS and dropped out. So there was a number of issues that happened. You know, some states closed facilities. So, but at the end of the day, 28 of these facilities completed, and over 50% significantly reduced the use of restraint by hours in individual events, and over 70% significantly reduced the use of seclusion by hours in individual events. And so for an evidence-based practice, these findings were considered extremely robust and important. And so in 2012, the 6-core strategies was adopted as an evidence-based practice for the prevention of conflict and violence that lead to the use of seclusion restraint. And I want to emphasize the prevention piece. So what we've learned since then is that when you endeavor to create a systemic practice change in your facility, let alone the country, but in your own facility, what that requires is a culture change in your treatment setting. And these changes in practice result in other changes that extend beyond the use of use of seclusion and restraint, especially when it comes to creating environments of care that are trauma informed. When we talk about this kind of culture change in our settings, what we're talking about is looking at staff and client interactions, how staff view seclusion and restraint and the violence and conflict that occur in their settings, and how we define recovery, developing resiliency in the people we serve, and how do we transform our environments of care. And those are all really important pieces when you're looking at a culture change like this. But it also it's complicated. This isn't like just changing one or two practices. This kind of work is what we often call peeling the onion. And the more you get to know your own facility and the staff that are working there and the environments of care and how that environment of care is experienced by the people we're serving, the more you learn about what needs to change. So the development of the curriculum, again, started in 2001. It included an ongoing review of the literature back to the 1960s, and that has continued to the present, because as more and more people have adopted the 6 core strategies and published on that work, we've learned more and more about how that works and what needs to be done. We also, again, learned a whole lot from our subject matter experts back in the day that had actually done this work in the field on their own. We also learned a lot from the people that we serve, service users or patients or whatever you want to call them, family members of those same people, and staff experiences. We interviewed hundreds of staff and hundreds of consumers to find out what it was like to have to restrain somebody or to be restrained or secluded. Again, the focus groups were held in 2000 and 2002, and the core strategies emerged. Now, an important piece of this and any evidence-based practice is that it's built on a foundation of core values and beliefs. So we had to early on choose our model from which we're going to base the 6 core strategy evidence-based practice. And so these are the concepts or the values that we chose to develop this practice on. So the 6 core strategies rest on these beliefs: leadership, principles for effective change, which basically says this is not something that direct care staff can do on their own. The leadership of every facility and every agency needs to take this on, make it a priority, and then help their staff get to the finish line. Also, the public health prevention model, which I'll talk about in a second. That we believe that people with serious mental illness, serious emotional disturbance, and other kinds of behavioral challenges can recover, and that they can build resiliency, and that they can learn how to manage their own emotions so they don't trigger and get escalated and sometimes violent. We also believe that patient and staff reports have extreme value to leaders who are trying to run services. And if we ignore the patients and our staff and what they say, we're going to miss the boat. Also, the emerging science of trauma-informed care back then, which really also hit the field like a lightning bolt. Up until then, we had never really thought much about trauma in general behavioral health. Unless you worked at a rape crisis center or a domestic violence center or with veterans returning from war, most of us knew nothing about trauma. And the same goes in our educational and academic curriculums. We didn't learn anything about trauma back then. So it was quite surprising and even shocking back in the very early 2000s to start to see the literature that was getting published on the fact that up to 98% of the people coming in to the public sector behavioral health service system had significant life experiences of trauma, and that trauma had changed the way their brains had developed, and in many cases had created situations where they did not know how to manage their strong emotions and would immediately react into fight or flight. That information, again, hit the field like a lightning bolt. And so this was all going on at the same time as we were implementing the 6 core strategies. And then last, the fact that continuous quality improvement, which some of you call quality assurance and some call performance improvement, was critically important in healthcare. We had talked about it for years, but I don't think it even hit me until we started doing this work on seclusion restraint, how important this was. And in terms of reducing the use of seclusion and restraint, what we found is that staff had to feel safe enough to be honest about what was happening when seclusion and restraint did occur, and what we had done and what we had missed and what mistakes we had made, so we could actually inform our practice and do better next time. So when we talk about continuous quality improvement with regard to preventing violence and conflicts that lead to putting hands on, what we're talking about are staff being able to sit back after the event takes place and talk honestly about what happened and not be worried about getting in trouble unless there was some kind of egregious break in policy. Like, obviously, if a staff member slaps a patient across the face, that's an egregious break in policy. But that's not usually what happens. What usually happens is we didn't know the client well enough, we didn't act quickly enough, we missed information on admission, or we didn't write the information that we got down in the treatment plan. We didn't engage the person well enough when they first came in, so we really didn't have a connection with them when they got upset. In some facilities that had developed so many rules that it was impossible for everybody to remember all the rules, and so patients would, quote unquote, get in trouble, or their privileges would be taken away, and they'd get angry. So that continuous quality improvement became extremely important. So the public health prevention model, I'm just going to talk a couple minutes about that. For the public, all of you guys now, after COVID, after a pandemic, are experts in your expert public health prevention people, whether you know it or not. And what that means is the public health prevention model is a model of disease prevention and health promotion. And it basically was the NASHPD Medical Directors Council, which were the medical directors in all 50 states and 5 territories back in 2000, came together and identified the public health prevention model as the perfect model to basically base preventing violence on. And that's because the public health prevention model is designed to look at factors that lead to a problem, and in this case, in public health, it's usually a disease, and then how to figure out how to avoid that, or worst case, minimize those negative consequences from someone getting that disease. In this case, our disease was having to use seclusion or restraint on a person. But the public health prevention model, just like COVID, the public health prevention model has been used for hundreds of years to basically prevent large-scale population illness, like from the flu every year, from HIV/AIDS, osteoporosis that older women get after menopause. And so what the public health prevention model does is it says, we got to put all our work upstream before the disease or the problem, restraint or seclusion, happens. And we need to keep everybody safe while we're doing that. So in primary healthcare, primary prevention, also called universal precautions, are interventions designed to prevent disease from occurring at all. And so, having just gone through COVID, we all know about hand washing. If you didn't know about hand washing before, you know about it now. The use of masks, social distancing, vaccinations. Those are population risk factors when it comes to COVID, the flu, and many other issues that plague human beings. A risk factor for young women being getting pregnant, by accident, getting a STD, sexually transmitted disease. So condoms are a part of the primary prevention model. The use of clean needles. Secondary prevention are selected interventions, are interventions that we take once the disease process has started. What do we do to prevent it from getting worse? So osteoporosis prevention is a really good example. We cannot stop the loss of bone density in postmenopausal women. It's a physiologic aging process. We can't stop it. What we can do is put people on medication to artificially strengthen their bones so that when they slip and fall, they don't break a hip. Same thing, we missed the first step, which was to keep someone from getting addicted in the first place. So now we've got someone who's addicted and is using needles to get high, but they haven't yet gotten hepatitis C or HIV. So what do? We set them up for a clean needle exchange program. Well, we work with them on recovering from their addiction, but that keeps them more well than otherwise. And then the third intervention, tertiary prevention or indicated interventions, is what happens when the disease happened. We missed the boat. We didn't know what was going on. It happened. And so what do we do here? And these are interventions that are designed to mitigate the disease process, to either to stall it, slow it down, and try and make that person's quality of life as high as we possibly can. So applying the public health prevention model in seclusion and restraint reduction goes along the same steps. Primary prevention or universal precautions, these are interventions that we want to put in place that are designed to prevent conflict from occurring at all. Because if we have no conflict and everybody's happy and everybody's at Disneyland, people are very unlikely to punch each other. So what we do is we try and anticipate our risk factors. We try and provide great customer service on admission, and we try and decontaminate any past negative experiences that a person may have had in inpatient or residential programs, especially if they were involuntary. And some of those issues include addressing, when someone goes into one of our programs, especially in an involuntary setting, they lose a bunch of their civil rights. And I don't think we often understand how devastating and odd and angry that can make people. We take away their phone. I mean, every 14-year-old has a phone nowadays. We basically tell them they can't do certain things at certain times. We tell them when they need to get up and when they need to go to sleep. We tell them what they're going to eat and how much. We tell them when they can call a friend or not. We tell them what they need to wear. We basically take away people's independence and freedom. And I don't think a lot of times, because we work in these settings, we understand how hard that is for someone to wrap their head around, especially if they've been brought there involuntarily. And of course, that makes people angry and stressed. And so people are likely to respond in ways that maybe they wouldn't normally respond. Or folks that have had a number of these experiences in the past rapidly respond without even really thinking about it, because that's how they've learned to survive. So primary prevention strategies are critically important and have a lot to do with staff training and the environment of care. Secondary prevention is what we do if everything's going on fine, and then a conflict starts to arise in our environment. What do? We sit in the nursing station and kind of wait and see if it gets worse? Do we immediately get up and respond to whatever we think is going on because we heard someone yell or we heard somebody throw something? What do we do on admission to give us an idea who our high-risk folks are? Are we using a trauma assessment? Are we helping people develop calming plans so that if they do start to get dysregulated, we have a plan in place to help them get regulated and before anything happens? How do we engage people that are hard to reach? Use of peer support, invaluable. And then tertiary prevention. There's only one tertiary prevention strategy in the 6 core strategies, and that is rigorous debriefing. And that is where we, for whatever reason, we had to put hands on somebody. So what are we going to do afterward? We're going to debrief it. And that's mandatory. And again, leadership coming into play and saying, staff, we've got to figure out what happened, what went wrong, and how do we avoid this happening again. And so what that means is we're immediately after the event gathering information, writing it down, and making sure that we avoid groupthink and that staff feel safe enough to talk about what did happen, what went wrong, what what went well, and what do we need to do next time, whether it's for that individual patient or all the people in care. And sometimes there are policies and procedures that need to be revised. Sometimes there are lists of rules and regulations that have developed over the years that we don't need, and that were put in place for staff convenience in many cases, and anger people, and we don't need those rules and regs. I'm not saying that we take away all our rules and regulations. What I'm saying is we critically look at them and make sure that we actually need those rules and regulations, that they're based on safety. Trauma-informed care, we're going to have a presentation with a number of presentations on trauma-informed care. So again, like I mentioned, it's an emerging science. We know a lot more about traumatic life experiences and how they cause or complicate mental health or other problems, including resistance to treatment. We also know that when we use seclusion and restraint, we traumatize people. And we also know that we need to use universal precautions on everybody walking in our door, because we will never know for sure what their trauma history is, because some people will never, ever, ever talk about it. So the 6 core strategies to prevent violence and seclusion and restraint are these: leadership toward organizational change, using data to inform what we do. It's 2023, and we're way past the time where we have to sit around a table and make stuff up. We've got to use data, and to use it, it needs to be clear and easy to understand. You should not need a degree in statistics to be able to understand what your data is telling you about seclusion and restraint. We need to develop our workforce, because the competencies that staff need to do this work, we were not born with. So we need leadership, and leaders need to basically provide that training and then coach, mentor, and monitor it for staff. We need to implement very specific seclusion and restraint prevention tools, which include assessment tools, safety planning, and a number of other tools. And we also need to look at the full inclusion of the people we serve and their families in all of our activities, whether that's through advisory councils or internal hospital councils for people that stay in longer term facilities. And then finally, to make debriefing rigorous. So I'm going to end there. Welcome to the 6 core strategies. We hope you will experience this training as helpful. We are not here focused on telling you you've been doing this all wrong. We've all been learning over the years, and that's how evidence-based practices work. As we learn more about what we do, our practices change. And unfortunately, seclusion and restraint has been one of those practices that nobody paid a lot of attention to until pretty much now. So we just want to share this new knowledge and help you become a subject matter expert, no matter where you work now or in the future. So thank you very much. And I'm just going to end with a quote that many of you have heard before, but I think it's incredibly important. And it was a quote by Martin Luther King, who said that that violence is the language of the unheard. So thank you very much. I'm going to turn it over to Beth Caldwell, and I will stop sharing.
Thank you so much, Kevin. And Dana's actually going to be doing my PowerPoint, so I'm very excited to have him do it. So good morning, Massachusetts. I'm actually in Massachusetts. I'm in the Berkshires. And I've always thought that Massachusetts had the best looking people and those with the highest IQ, but I can't see anybody. It's really hard to try to do a training and we're not able to see everybody. So anyway, I am the 6 core strategies faculty. Like Kevin, I have worked in Massachusetts for many years. And I've actually been working closely with Dr. Kevin Huckshorn for many years. And she is hands down the most effective leader I have ever worked with. So we're all gifted to have her with her deep knowledge as a faculty for this training program. So we're going to do a module now called Current Assumptions. If you go to the next slide, please, Dana. we're going to basically kind of sniff the assumptions, or maybe we're going to call it speed dating the assumptions. And I'm going to make an assumption that everybody here, whether you work in a school, whether you work in a residential program, a hospital program, a community program, whether you serve adults or children or adolescents, that you're actually have someone in your program, in your school, that has some of these following assumptions. So one of our goals is for you to not only hear these, but actually feel free to start using these assumptions to support training of your staff. Now, one of the things one hospital did is that they actually had a big bulletin board and they put up these assumptions and different realities against those assumptions for all staff to see over the period of a year. Another hospital that actually had, we're still using one of those time card pieces, they put up a different assumption every 2 weeks with the reality. So think about how you can use this to support your own self, but also mostly your staff too, back in your particular program. And next slide, please. So we're going to be looking at all these different assumptions. And some of you, probably most of you, have heard of Sufism. It's a type of religion, or at least a philosophy. And in fact, I just had a driver the other day when I flew into JFK who actually was a Sufi. And Sufis have a saying that before you talk, your words should go through 3 gates. And the first gate is what I'm about to say true. And if it is, then you continue to the second gate. And the second gate is what I'm about to say kind. So if it's true and it's kind, you keep going to the third gate. And the third gate is what I'm about to say, is it necessary? And if it is, then you say it. And so when we're going to be looking at these different assumptions, we're going to use that first gate and ask, is this true? So next slide, please. So what is an assumption? It's right here. And then the second part of that slide too, please, Dana. So it's a belief that's supposed to be factual, something taken for granted, or a supposition. And remember, some assumptions are actually based on facts, but what we're going to see is many are actually based on myths. So the first assumption, next slide, is restraints and seclusion keep the people we serve safe, the children, the adolescents, the adults, in whatever type of program we're in. So the question is this true? So the next slide tells us that reality is different than this assumption. Kevin mentioned the Hartford Courant, your own Connecticut neighbors, and what they actually estimated, they found 142 deaths in that 10-year period. One study in New York State actually found 111 deaths over 10 years just in their own state-operated programs. Texas found 16 children died, and this is another local media like the Hartford Courant that went and started looking at restraint deaths. And then our own, some of you have heard of therapeutic crisis intervention from Cornell University. And so the coordinators, the leaders of that program are fabulous researchers, and they actually did research into child residential programs and found 67 restraint facilities. Next slide, please. The World Health Organization did a comprehensive review just last year, so WHO, as we know it, and they actually found that restraints can cause death and that we should work on prevention. And that's what this training is really about, is how do we work on prevention? And then, of course, one of the most esteemed reports was the Harvard Center for Risk Analysis, which I think Kevin mentioned also. But what they found is that they're estimating between 50 and 150 deaths occur every year due to restraint or seclusion. And then the federal office in the Inspector General found that many restraints, 42% of them were actually, deaths from restraints were not reported. And so we have to not only, as Kevin talked about, really use that data and be very clear about everything, but we have to really understand how serious the reality is that restraints do not necessarily keep the people we serve safe. It's certainly on the next slide, gets very serious quickly when we put names and ages and people, actual people behind this. Restraints did not keep Rick safe. Rick died of cardiorespiratory failure when he was wrestled to the floor, and he is actually bound in leather restraints. The next slide is William. Restraints did not keep William safe. William died after 4 minutes of a prone restraint. William was known because he loved card games and Garth Brooks, and the event was ruled a homicide as staff actually disregarded that policy of never using prone restraint. So the next slide, restraints did not keep Irvo safe. This is a particularly sad one. All are extremely tragic and sad, but what they say about this young man is that he was a music maker, a rapper. He was reported very kind and soulful. He was restrained for 12 minutes, died from asphyxiation. And actually the 3 staff and the 7 deputies were charged with homicide, but of course it didn't bring him back. And the next slide, please. Restraints did not kill Janella safe. She actually left. She had 18 hospitalizations, and she left with a cast and a broken leg that 18th hospitalization from a restraint. And she said, if I have to return to this particular hospital, I'm going to die. They're going to kill me. And in fact, that's exactly what happened at her next hospitalization. She was restrained within 5 hours of arrival. She actually got out of the restraints, walked out. 15 staff wrestled to the floor. They held her face down. They noticed that she was limp. One of the staff noticed that she was limp, and another staff said, oh, she's just plain possum. So they put her back in restraints, checked on her, and discovered she actually was not breathing. And the next slide shows us that restraints did not keep little Tanner Wilson safe. On the first day in the program, in a residential program, he actually was restrained and his leg was broken. Later, back at the program, his leg was broken a second time. 18 months after being admitted, when he was only 11 years old, he died in what they called a routine physical hold. He died of asphyxiation. Restraints did not keep little Tanner safe. And the next slide, please. Restraints did not keep Joshua safe. And we know that these are hard slides to see and to hear about, and to hear especially about like what his family members said. His mother said, it's a nightmare that people have to go through this. All my son needed was some help. This shouldn't have happened. So he died due to restraint. And when they said that he allegedly assaulted 2 of the staff, so he was restrained in that prone position, but his assault behavior, when they looked at it later, was actually just waving his arms in the air. The next slide, please. So there are numerous injuries and deaths annually because of restraints. As one program leader shared, there, but for the grace of God, goes one of the people that we serve. Each of us has seen rug burns. Each of us has seen people with cuts due to restraint. So it's a false assumption that restraints keep those people we serve safe. And the second assumption on the next slide, restraints keep staff safe. Is this true? Go to the next slide, please. These 4 realities help debunk that assumption that restraints keep the staff safe. Restraints didn't keep these staff safe. All of them died due to a restraint they were involved in. 3 were kicked in the chest during the restraint. Next slide, please. An organization in Virginia tracked restraint use in their residential treatment centers and community programs. after making a total commitment to prevent, reduce, and to focus on eliminating the use of restraints. They were quite successful, as you see. And what they also found, if you go to the next slide, please, Dana, is that as they reduced restraints, and this program is UCARU, is that they actually also saw the same reduction in staff injuries. This has been shown again and again and again as restraints come down, and we're very serious about using those 6 core strategies, staff injuries go down too. So it's a false assumption that restraints keep staff safe. And if we can go to the next slide, please. So that leads us to the third assumption. Restraints are used only when absolutely necessary and for safety reasons. Is this true? Next slide. So Andrew McLean was 11 years old. He weighed 96 pounds when 2 aides at this program actually restrained him, and he died. And why was he restrained? He was sitting at a breakfast table, and apparently all the youth at that table are being loud. So one staff who thought his job was to be a rule enforcer went over, asked them to quiet down. They didn't. So he said to Andrew, you move to the other table. You move, go ahead and move. And when he didn't move, staff kind of, helped him get up, and he pushed away. And then the staff tried to get him stronger. So he kicked at him and started running. He was chased down the hall, took him down to the floor. He died because he did not move from the breakfast table when asked, and because staff thought their job was a rule enforcer. And a similar kind of situation in a residential program in Texas, a juvenile justice facility, actually, a 15-year-old girl named Edith was carrying a piece of paper, and they had to line up to go from the program to the school, and they were not supposed to carry anything with them, have nothing on them themselves. So a staff member who thought his primary job was a rule enforcer said to Edith, let me have what you have in your hand. She said no, put it behind her back. He said, I told you I want it. She said no. He went to grab it. She pushed him away. He then ended up restraining her with others. She died due to the restraint. After the restraint, they found it was a letter she had just received from her sister. In Michigan 4 years ago, in a residential program, there was a young man who died due to a restraint. Similar to Andrew, he was sitting at a lunch table, and there's videos of this. It's actually on the internet. And he didn't like his sandwich and threw it, and ended up in a scuffle with staff. It ended up in a restraint. But the most tragic part of all is that staff throughout, and the other youth throughout, did not pay attention at all. Nobody really paid attention when this youth, for throwing a sandwich, was put down on the floor and restrained until, of course, they found he died. So next slide, please. What we have here is Troy. He died due to restraint. Troy's restraint was not necessary. His behavior, another one of waving his hands, did not meet the criteria of imminent danger. Next slide, please. Mark died due to a restraint in the same way. He refused to go to the gym. They asked him twice. Once again, staff feel it's their job to be a rule enforcer. When he did not go to the gym and he refused, he actually ended up in a restraint. And so currently in America, you can refuse to go to the gym. So it's not true that restraints are used only when necessary. Next slide, please. It goes to assumption number 4. Staff know how to recognize a potentially violent situation. Is this true? I think you're going to start knowing the answers to these. If you can go to the next slide, please. Only going to share a couple of these summative research studies. And basically what they're finding is that at best, trained mental health professionals alone can only predict the potential for violence somewhat better than chance. And actually it increases when multiple sources of data are used, but research does not support that staff know how to recognize potentially violent situations. So if you go to the next slide, please. Assumption number 5, staff know how to de-escalate potentially violent situations. And is this true? Let's go to the next slide. Joy Duxbury actually analyzed 221 reported incidents of aggression and violence over a 6-month period in different psychiatric units. And she found that actual de-escalation was used less than 25% of the time. And staff, when they were interviewed, identified that they had a lack of training. In fact, the Joint Commission here in the United States posted a complete description of staff training and competencies for effective de-escalation because their reviews found that there was a lack of these core competencies in the behavioral health field. So we need to do a better job in ensuring that staff know how to do many things in terms of preventing, but also specifically in de-escalation. And that leads to the next slide. The 6th assumption is that it says it's not possible to reduce restraint seclusion in programs serving special populations. You know, now this is not true. Go to the next slide, please. As Kevin said, way back when, we had all kinds of representatives when they were coming up with the 6 core strategies, programs that had been successful. So intellectual and developmental disability facilities, yes, they have prevented and even eliminated. Forensic facilities, yes, they have seriously reduced and prevented. Next slide. Adult facilities, your own hospital here in Massachusetts, 2 of them actually over time. One actually eliminated for a period of time, and a number of children and adolescents programs and residential programs across the country, including a number in Massachusetts, had either eliminated or seriously reduced. And if we go to the next slide, you also find in just emergency rooms that they have significantly reduced. And you know what happens when people come into emergency rooms. It's happened in schools, it's happened in day treatment programs. It's possible to prevent and reduce the use of restraint and seclusion with special populations across systems, behavioral health, juvenile justice, prisons, child welfare, schools. And the next slide leads us to the 7th assumption, which is restraint and seclusion are not used or intended to be used as punishment. Is this true? Well, if you go to the next slide, outside of getting approval every time you have a gentle, kind touch of a person you serve, maybe it's an air hug or maybe it's a tap, you know, to see how they're doing, if somebody wants that. But outside of those very specific, yes, you can touch me kindly, is that anytime we put a hands on for any reason other than imminent danger, we are actually using seclusion and restraint for consequences or actually for a punishment. And so if you go to the next slide, even in your own Massachusetts Children's Unit, I believe this one has been closed for a while, but they had eliminated mechanical restraint, medication restraint, seclusion, and they were trying and moving to eliminate physical restraints or holds. And what they analyzed is 28 of those holds that they had over a 3-month period. Everyone was under 5 minutes and 68% of them were under 1 minute. But what they did is they interviewed the children a while, like months after the child had been in this hold or physical restraint. The children perceived that their restraints were lasting at least 5 minutes and up to an hour, when again, all were under 5 and most were less than 1 minute. And they talked about, even though it was post this event, and these are, you know, children under 12, that they were talking about how fearful, how upset it made them. And then in fact, that fear and that being like almost rageful returned to them when they had to think, when they thought about this again. So the next slide, and there's other studies that say this too. This is an important slide to go back to. People who were secluded experienced vulnerability, neglect. They sensed a sense of punishment. They also stated that anger and agitation were the result of being placed in seclusion. They're associated with negative emotions for the people we serve. They feel they were punished or feeling distressed. And in fact, if you look at the deleterious effects, they have things like post-traumatic stress disorder. There's actually a correlation to increased length of stay, revival or previous trauma. So all of these show us, in fact, it is not true that restraint and seclusion are not used as punishment. People perceive it as punishment, and it's often used like that. And that goes to the 8th assumption. Next slide, please. Is this true? Is that seclusion and restraint are used without bias and only in response to objective behavior. And of course, we now know that this is not true. If you go to the next slide, there's a number of summaries of the research that indicate that culture and social bias may exist actually. Those more likely to be secluded are actually Black and Asian descent. Those more likely to be restrained are younger and on more medications. And so, and also in another study, it's the younger, the male gender, the Black or Hispanic descent. And an important study that came from our colleagues across the ocean is this, the next slide, please, is this study that happened, or an assessment that happened after a man named Rocky died due to restraint in a UK hospital. He was being racially abused by a white consumer, and he actually lashed out verbally at a nurse. He was actually held in a prone restraint for 25 minutes by 5 staff, and he died. And his sister actually worked as a nurse, not there, but in the UK. And she asked to have an inquest into his death. And when they actually did that review, they found there was significant institutional racism in their national health services. And so the next slide. So what happened is that his death and subsequent inquiry actually led to this 5-year plan to implement new practices. And 2 of the key recommendations are limiting any type of restraint to less than 3 minutes and addressing this institutional racism that they found rampant in their system. And in fact, their Count Me In, next slide, please. Their Count Me In which is a booklet that was published back in 2005. They found some really disturbing information. Look at the data. Look at that. Twice as many people who are African Caribbean descent, twice as likely to be sent by the court, to be sent by the court, 20 to 25% more likely to be detained than whites, 29% higher restraint rate, and a 50% higher seclusion rate. So it's very disturbing. And so we need to know, and also if you go to the next slide, it's not just in the UK. Some of the earlier research I showed on this actually showed it was across the United States. And this is actually data from a New York study. And what they found is really inconsistent use of restraint and seclusion across their facilities throughout New York State, serving people with the same referring challenges, the same admission challenges. And so there's very disparate clinical perspectives on the advisability of restraint and seclusion. If you go to the next slide, you can see actually here that there's all the different facilities and what's the use of restraint and seclusion. So it really gets down to, do you, the staff, do you really, as Janice talked about earlier, at that very first seclusion, 6 core strategy training, everybody was all the hospitals were supposed to send teams of leadership staff, and one program got it wrong and they sent a direct care staff, and she went back and knocked on the door of the CEO and said, we have to do this. And in fact, they did it. So it depends on the staff, all of you joining together to say, what are we going to do to keep the people we serve safe and to keep actually ourselves safe too, and the rest of our staff. And that leads to the final assumption. Next slide. Some people say seclusion and restraint are therapeutic interventions, and based on clinical knowledge, is this true? So if you go to the next slide, the gold standard of reviews or summaries or Cochrane reviews, they basically research extensively, look at all the research in a particular topic area, and their research into the use of restraint and seclusion, what they found is that we should have very serious cautions about use. It's very dangerous, that seclusion and restraint efficacy and therapeutic value have not been established for the people we serve or for staff, and as there's serious adverse effects, as we've talked about. So the reality is that seclusion and restraint are used in the hope of preventing injury and reducing reducing actually agitation. But many studies actually report substantial negative physical and most often psychological effects, not just with the people we serve, but also with our staff. There's numerous unfounded beliefs. There's harm in restraint and seclusion. There are very few positives. If any, they're not substantiated. Biases exist in our system. There's not an evidence-based practice, and significant culture change is required if we're going to prevent, reduce, and actually we can begin to eliminate. So the worst punishment deemed possible in prison is seclusion or solitary confinement. But when people behave inappropriately in some of our programs, and even in schools and sometimes, and residential, and in hospitals, that sometimes they're put in seclusion. And the only difference is that we sometimes call it at best necessary, and at worst we call it therapeutic. So the next slide, please. As Dr. Kay Redfield Jamison shared in her book, Night Falls Fast, the breach between what we know and what we do is lethal. And I hope that you share some of these assumptions and realities with other staff in your program. The assumptions are not true, that you're also fine, restraint and seclusion are not kind, and they're not necessary. So thank you very much. Now what we're going to do is Kevin and I are going to be available for questions that people type in. And I don't know, Kevin, if you have actually seen any questions yet that have come in the chat box. And Dana, I don't know if we're going to be able to actually have anybody raise their hand and ask a question.
Yes, please use the raise hand feature if you'd like to speak. Otherwise, come into chat. I do want to point out a question that we received a little bit earlier from Tracy. Tracy asks about if there are any recommendations for evacuating patients, especially in the event of emergency, especially those patients that require 1-to-1 or 2-to-1 coverage. There's very little guidance at the institutional level.
Kevin, did you want to take that one?
Sure. Well, I would say, first of all, evacuation processes are very specific to the population that you're serving and the setup of your facility. I mean, some facilities you can bring them into the courtyard and they're still, they're still in an enclosed situation. So it's kind of hard to answer that question, but every facility should have an evacuation process that accommodates for people that are either involuntarily committed or who require 1-to-1. One of the things that is true is if you're evacuating a group, even if it's only 3 staff, you're basically still being able to do line of sight for everybody. And so, sometimes you can't stay with a 1-to-1 in that kind of a situation if you're not staffed adequately for that. But I would really get with your leadership if there are questions about that, because, at any given time, you might have to evacuate, either flood, fire, natural disaster, who knows? So if that's not clear in your policies, I would definitely get clarity on that. But again, it's pretty different from facility to facility. If you look at like a facility like Bridgewater State Hospital, which has all involuntary committed forensically involved people, that's going to be quite different than a 20-bed residential program that's, has a 3 to 6 month to year-long length of stay. So again, like that, I would be concerned if staff don't know how to safely as possible do an evacuation. But if the question is also, we wouldn't restrain or do things like that to evacuate, because when you're evacuating, it's life or death kind of stuff, and you just do what you have to do to try and keep as many of the big group safe.
Brenna.
Hey, so I just wanted to ask, in addition to education and debriefing, are there other cultural changes or things to build into the culture of a facility that can help support staff in reducing restraint and in feeling really supported in production practices day to day?
Great
Brenna.
question, Brenna. And I would say, well, we're going to cover that. I'm going to do a PowerPoint on leadership later today. And in one of the next sessions, I'm going to be talking about workforce development. So we're going to cover a number of those strategies because there are many. And so it's much more than debriefing. And it starts actually with new hire interviews, job descriptions, onboarding, training, supervisory coaching, and role modeling. There's just a lot of strategies that can be put into place to help staffs and support them in doing this work. So I'm not trying to defer your question, but we are going to cover that.
Right. Just to add to what Kevin said, Brenna, first of all, I have a godchild named Brenna, so that name's important to me. But your question actually just gets to the very bottom of what we need to do, which is we need to give staff tools. We need to set a foundation, basically, of staff understanding and leadership, which Kevin will go through, as you said, commitment to certain values and operationalizing those values. And so not until the last session of the training, the fourth session, will we actually get into specific prevention tools, which is like safety or soothing or calming plans, use of sensory, but we'll be mentioning them throughout, and each of them will be giving examples. And what your question really gets to is after you and your team, or just if you're the only one on your team that goes to this training, is going back and meeting with some of your colleagues, your leaders, we ask you to come up with a prevention plan, a plan for your program to move forward. Again, whether it be a school or whether it be any other type of program, a hospital or residential program, is that you come up with a plan and you start choosing what we call low-hanging fruit. What are some things that we can improve right now? And we hope, because it's happened in all of our previous trainings, you're going to get a lot of ideas about what you can take, low-hanging fruit that you can take back and begin to address exactly your question. So thank you for that great question, Brenna. And I think we have another question in chat.
Yes. I'm trying to find it. Okay. Question regarding model application and seclusion and restraint reduction, tertiary prevention. Can you please elaborate on avoiding groupthink documentation post events? Is that referring to staff debriefing and documentation post restraints? Yes, Angela. Okay, so groupthink, what we recommend, and we will be covering this also in detail, but right after the event, we recommend that there's what we call a post-acute event debrief, and that is a huddle. So that is everybody that was just involved after you've gone around, you made sure everybody's safe, you've made sure everybody, you're trying to get the milieu back to the environment of care back to kind of pre-crisis. You immediately huddle with anybody that was involved in the actual event. And one of the ways you avoid groupthink is to have everybody that was involved just take 5 minutes and write down what they think just happened. And the reason that's so important, and if anybody knows a police officer, especially a traffic cop, you can ask them, human memory is really sketchy. And so and you can ask any officer who's interviewing after a car accident, who's interviewing all the witnesses, and they'll get 10 witnesses and 10 different reports on what just happened. And that's kind of what happens in a seclusion and restraint event. People are in different parts of the unit. They knew or didn't know the patient. They knew or didn't know what happened ahead of time. And so you get all kinds of different responses. However, if you stick everybody together in a room and ask one person to tell you what happened, that one person's description will often color everybody else's memories. And so what we do is we really try to avoid that by asking everyone to jot down, without talking to anybody else, what they think just happened, and turn that information in to the supervisor that should have showed up on scene, and hopefully somebody that was not involved in what just happened. In our experience, very, very, very rare is it that someone just explodes. That it just doesn't happen. There's always precursors. Just because we didn't know the precursors, or we weren't paying attention, or we didn't know the patient well enough, or something happened yesterday and nobody talked about it in a report, doesn't mean that there weren't any precursors. So again, there's usually a buildup of something happening depending on that individual patient's tolerance for stress and distress. So that's what we're talking about, is to really try and avoid groupthink, and to really try and create a safe environment for staff to disagree on what they saw. And we will be talking in much more detail about that over the course of the next couple trainings.
Thank you, Angela, for such a good question also. And so we also, for people, as you think about this, like when you go home tonight and you say to your significant other or your friend, like, oh my goodness, that was the best training. Those young, good looking faculty just really inspired us. Is that jot down any other questions. We're going to be having questions at the end of this session today. We'll be having questions in the morning again. So bring questions at any time, or thoughts or ideas. So we want to hear from you. It's, as you know, we like to train live because we can really connect with you, but please jot down questions at any time, middle of the night, and then bring them to us, tomorrow, or now in a few minutes. We're going to go for a break. If you come back, we'll deal with your, address your questions right after the 2 sessions that come after the break. So are there any other questions I think we have a chat box, or that might just be Angela saying thank you. Or do we have, I said the Massachusetts people were the best looking and the smartest. They're also the most polite. I forgot to mention that. So any other questions or comments or needs? Please let us know your needs. There is an evaluation for CEUs, but anybody can actually fill it out. So if you have any feedback for us, you're going to fill that out after this session, and to give us feedback for how to improve next, tomorrow and next week too. So so why don't we go a few minutes early? Can we do this, Dana? Can we go early to the break and then start early with leadership? Do you feel comfortable with that, Dana?
Of course. So the time is now just past 10:25. Let's return at 10:41.
Okay, we're counting on you guys. 10:41, and everybody has to stand up and move around. You may not stay seated and do just your email. Okay, thank you, everybody. See you in 15.
I'm just going to get started. So first module on the first of the 6 core strategies, and I'm keeping my video off in an effort to improve my audio. Effective leadership strategies for organizational change. Next slide. So first off, I just wanted to mention that there has not been a terrific amount of research on leadership in behavioral health. There's obviously hundreds of research articles on leadership in other types of systems like manufacturing and business and those kinds of things. So just wanted to note that we based this module on a number of very specific studies that were on seclusion and restraint reduction, and the work by Bill Anthony, who actually was from Massachusetts, widely recognized as the psychologist who identified the concept of recovery and resiliency way back when in the 70s, before any of his colleagues even talked about that, and is widely noted as the father of recovery in behavioral health. And also my own research on leadership that actually took place in Massachusetts in 2 of your facilities. So next slide. So preventing seclusion and restraint is to prevent the precursors to violence. And it changes the way we do business, regardless of whatever healthcare setting that you're in or who you serve. Changes the way we view the people we serve, changes the way we see our own roles as staff. And with those changes results in a culture change. Successful organizational culture change requires effective, committed leadership from the top down. Next slide. Why is that important? Why are leaders so important, especially in culture change work? Because our organizational leadership are the ones that are responsible for what is happening in our facility 24/7, 365. Leaders also have the power to plan the strategies on action, to take action daily, to follow through, and to mentor and develop new leaders. Next slide. Formal leadership is probably the most important component in successful reduction projects. And I can say that pretty confidently because if you were to talk to any of the 6-course strategy faculty who've been doing this work for over 21 years, 22 years, we will tell you that the facilities and agencies, whether hospital or residential or emergency room or forensic or whatever, who have been successful had constant, consistent, committed senior leaders that were involved in these projects. And the states that continued to call us to come back over and over again had the opposite. Why is that? Because only the senior leaders can make seclusion and restraint reduction a high priority. Only the senior leaders can assure that the facility or organization develops a reduction plan so people aren't running all off in a million directions. Only formal leaders can reduce or eliminate organizational barriers, including revising policies and procedures. Only senior leaders can assure that staff are being provided the appropriate training, and only senior leaders can hold staff accountable for their practices. And that, when I talk about holding staff accountable, I'm really just talking about you've trained and trained and trained and mentored and coached, and you still have a staff member who just won't follow the values and the culture that you're trying to develop. And what that generally means, it's a bad fit. And so generally that person probably should find another job, and sometimes we help them find other jobs. But on the other hand, informal leaders also have very important roles. Next slide. Informal leaders are those folks that have a lot of influence with their peers and colleagues. Informal leaders use their influence to help model trauma-informed and consumer-directed care. They model compassion, respect, and listening skills, no matter what their peers are doing or saying, their colleagues. Provide feedback respectfully to colleagues on good and not so good practices in private, hopefully. welcome and work with peer staff and new staff, and they have the courage to make suggestions to supervisors. Anybody can be an influential, informal leader. Has nothing to do with title, has everything to do with personality. So do not think just because you don't have a management title that you don't have a very important role here. Next slide. So the power of leadership in creating change is obviously every leader has that power. But if they don't use it or they use it ineffectively, it's pretty useless. And it actually can become an impediment or a barrier to effective organizational change. Leadership on all levels is considered the most important and fundamental resource in any project that seeks to change their culture. It's critically important. And if you do any reading on any kind of culture change projects, I don't care if it's in healthcare or not, you will see that where that happened, and it happened well, the most senior executives were extremely involved. Next slide. So, fundamental principles of leaders. I'm going to go through a number of fundamental principles of leaders that come from the literature. The first is that an effective leader creates a vision. Next slide. The essence of effective leadership is the ability to motivate one's staff to action around a shared vision. So in this case, and what we're talking about in this training, is our shared vision is going to be spoken about like preventing violence and the use of seclusion and restraint, or creating nonviolent and non-coercive treatment cultures, or implementing a trauma-informed system of care. Implementing a trauma-informed system of care cannot be done if we're using a lot of coercive measures. So it goes hand in hand with reducing the use of seclusion and restraint. All of those visions will provide similar positive outcomes and get you to the goals that you want to get to. So it doesn't really matter so much the words that your leadership uses. The important thing is that that statement, that vision statement, is known to all the staff from the minute they're hired through their onboarding and into their work on a daily basis. So if you've got a policy and nobody's ever read it, and it's some, hanging on a wall somewhere on these issues, and nobody pays any attention, then that is not an effective vision statement. So the first thing we usually recommend for leaders to do is to unearth their vision statement on seclusion restraint. It's like a magnet. It attracts to it people with special characteristics. Generally, every time I have done this work in a facility and we've started this work, I've had a number of direct care staff come up to me and say things like, "Thank goodness you are paying attention to this. I am so glad someone is going to help us do better so we don't have to use seclusion and restraint so much. What can I do to help?" Again, vision or policy statements can be pieces of paper, or they can mobilize the organization in kind of a common cause and build teamwork. Next slide. Vision and policy statements on preventing violence can provide a sense of purpose and meaning to staff, patients, families, and the community. But they must be shared, and they must appeal to reason and emotions to be effective. Next slide. So setting clear outcomes. Part of a vision statement is to basically tell people what they can expect at the end of the day. So some of the expected outcomes that we would want to see once you're trained and you start to implement or re-implement some of these 6 core strategies is that you're going to see more staff that are competent in therapeutic communication, knowing how to negotiate to a kind of a win-win, mediate conflicts, and stay true to trauma-informed care principles. You're also going to see a reduction in seclusion and restraint events. You're going to see a reduction in staff and client injuries, because truthfully, people get hurt when seclusion and restraint is used. It's one of the most common reasons that people are injured in behavioral health environments of care. So if you reduce seclusion restraint, you're going to have less injuries. You're going to have higher rates of client engagement in care because they're going to be able to feel safe. People don't learn or even listen if they don't feel safe. That would be you, me, or anybody that we're serving in our organization. And you'll also see shorter lengths of stay after a while. Next slide. The vision should basically inform our policies, and our policies should be clear and easy to read. Our policy should be extremely clear about when seclusion and restraint can be used. And part of that is defining what imminent danger is. I think a lot of us assume that our staff understand what imminent danger actually is. But in reality, when I go around the country and do this work, I find that imminent danger is very poorly understood, and that many staff think imminent danger is swearing, throwing something on the floor, refusing to obey a rule, walking on the grass, a facility I just came back from, walking to school, talking on the way with your friends, your peers, your patient peers on the way to school. And people are punished for those kinds of things by either losing benefits or privileges. And it gets people very unhappy. Part of the policy needs to be a statement of your agency's goal to reduce and eliminate and why. And then you have to link this vision with your philosophy of care. And all of that's pretty easy to do. And my guess is, since you're in Massachusetts, that has been done. But as a leader, you may want to unearth that. And as a staff member, you may want to ask for that vision statement. And really, as you start to look at your policies every day, because you're using your policies every day, make sure it's congruent with the vision. And if it's not, and we're going to talk about that in workforce when the vision isn't congruent, we'll also talk about it a bit in a minute. It's very confusing for staff. Next slide. So the next principle is living organizational values. Next slide. Effective leaders create a culture that identifies and tries to live by key values. Dr. Anthony used to say that values are the organizational Velcro that basically connects your vision statement to your operations. So your values should not only guide what your vision statement says, whether it's your total vision statement or a vision or policy statement on reducing the use of seclusion and restraint and implementing trauma-informed care, to what your policies tell you to do. And leaders must be clear about these values. In a lot of organizations, they have meetings that review their organizational values every year or every 2 years, so they can kind of stay up to date, make sure everybody's clear, and then wordsmith those if that is needed. Because only then can you start to team build a team that shares the values that the organization wants to hold forth as the organization's goals and their approaches. So leaders must get clarity and consensus on the values if you want to create a different kind of environment of care. So for instance, changing a hospital or an agency or a residential program or any kind of service from one that is rule-based, institutional, and at times coercive, to one that is based on person-centered care that is respectful, is not shame-based, and that strives to avoid homogenous approaches. Homogenous approaches is that one-size-fits-all approach where we're basically assuming that everybody in care is kind of like the same. And that is a very big mistake to make, especially with regard to seclusion and restraint. Next slide. Policy, procedures, treatment activities, language, and rules need to be held up to this values threshold and measured against it. And when this happens, practices change. And the agency becomes more informed about making sure that their values and their practices are in alignment. Next slide. This takes a lot of time. It takes work. It takes discussions. It requires planning. It takes looking at things like token economies and point level systems, because those are not evidence-based and are often a one-size-fits-all approach. It also requires making sure that staff are trained on what the signs and symptoms of mental illness or serious emotional disturbance actually are, and that they're not signs of somebody willfully acting out. In med-surg facilities, we have a lot of issues there because staff in med-surg facilities mostly believe that they should not have to manage people, especially in the emergency room with behavioral health disorders, even though across the country, that's where a lot of folks go. That's why 988, the new 988 system was evolved and has been implemented across the country so that people have an actual place to go that are trained and skilled in behavioral health emergencies. But until that happens, all of us need to be competent in these issues. Next slide. Essential values for behavioral health services: safe care, do no harm; effective care, treat to stabilization and get the person out; efficient care, fast discharge; care that's respectful and person-centered; care that is recovery-based; care that empowers voice and choice, hopefully with peer specialists on board, because if a person does not feel they have voice and choice, they are very unlikely to follow the plan of care because they will not take no ownership in it. Care that is based on evidence and care that is trauma-informed. Next slide. So these are some examples of connecting values to practices. So the value would be person-centered care. The change is that person-centered care would include a wide range for wake and sleep times that adapts to an individual's choices and biorhythms, as compared to everybody gets up at 6 a.m. and goes to bed at 10 p.m. None of us all get up at 6 a.m. and go to bed at 10 p.m. And I would guess, if I was able to ask you, if I was in person and I was able to ask 10 of you, when you get up and when you go to bed, that is going to be a big range of times. Everybody needs a different amount of sleep, and everybody has different responsibilities. And so we have different habits. And in terms of the people we serve, they have medication side effects we need to take into consideration. They have maybe their own bedroom, or maybe they're sleeping in a room with 4 other people and somebody snores. Some have more need to sleep than others. Some have had terrible experiences at night and have a very difficult time going to bed because they remember trauma. So we have to accommodate those things through person-centered care. Next slide. Value person-centered treatment planning. I still go to facilities where the patient is invited to the team meeting, but nobody really cares if they attend. And they're only asked to sign the formal plan because CMS and Joint Commission expect them to sign. Sometimes they sign, and if they don't, the staff just refuse to sign. So that is not really person-centered treatment planning. In the facilities, in many of the facilities I've worked in, we made it mandatory that the person had to come to their treatment plan meetings. And if they refused, then that was the goal in the treatment plan, because we decided we couldn't really develop a treatment plan without that person's participation. So the treatment plan would be very minimal until the person would participate, and it would just cover medical issues, safety issues, and getting their engagement. And this takes real work. And the person to feel safe and to feel like anybody cares about them. And so it's work, but if you don't do it, you've missed the main part of the reason people come to us, which is to engage them into their own treatment so that they can then learn how to manage their own issues. Next slide. Least restrictive interventions. We've been talking about least restrictive interventions for decades, and that has been in the Joint Commission standards since the late 60s. However, I still see all the time a one-size-fits-all approach to behavioral health crises. First thing we do is we call a code, or we redirect and set limits, and generally that doesn't work, and the person starts to escalate more. Then everybody runs into the unit, and that escalates people even more, and then we move to holds, medication, and seclusion and restraint. So when we talk about those seclusion restraint prevention tools, that's where these come in. This is where the process of teaching staff how to manage de-escalation, develop customized safety or soothing plans on admission, and continue to work on them throughout that person's treatment stay. Offer early intervention choices based on that person's needs, preferences, and treatment plan. There is putting hands on someone because they wake up at 1 o'clock in the morning and want something to eat is ridiculous. And so you shouldn't have rules that say nobody can have anything to eat after a certain time. Someone who wants to call their mother or someone that wants to call a friend because they're in crisis, let them. Don't take away their own personal soothing strategies and make that a privilege. People need to have access to music, quiet, if they want to take a shower, and you'll learn more about that when we go through the sensory modulation training. But there's a lot of really important strategies here that any staff can implement to help someone de-escalate. Next slide. Value, inclusion, empowerment, and peer support. The current practice is often consumers are not included in the organization or are as tokens, peer support. They're not involved in operations. And if they're hired, they hold low-level positions with low pay. What we know now is that peer support specialists are incredibly valued in most every facility where they are hired. And I know Massachusetts was one of the leaders in hiring peer support specialists. I know it's harder to do that for young people's services, but it is possible. We need to look at salaries. When we're asking someone to potentially go off Medicaid benefits and take a formal job, we can't pay them less than they were getting in with their Medicaid services. And we can't expect people to live in poverty. So we really also need to look at peer support specialists, not just in direct care staff roles, but also in management roles. We also make sure that those peers report to senior staff and they're given accommodations and their support structures in place. And hopefully that they're not the only peer support worker in the entire organization, because that's a very tough job to hold if you're the only person. Next slide. Respect and dignity are assured, that we learn basic customer service principles like in Disney World or Marriott Hotel, that if we have an issue, we're going to have respectful private discussions about behaviors, that level status or privileges and practices are reviewed for a literature base. There's absolutely no problem having incentive programs, but when you've got practices that take away levels or remove privileges, you really are going to want to look at that. And also organizations where power differentials are minimized and patients are treated as we would want to be. And when I say, I'm talking something as simple as not wearing key rings outside your clothing that bounce around on your waist, because what that says is that I have all the power and you don't. Next slide. Seclusion restraint are only used for imminent danger. Again, this imminent danger needs to be well described in policy. And all staff need to understand that if a person in care comes up and breaks a piece of furniture, knocks over a TV, hits someone and then walks away, throws something, lies down in the middle of the floor, spitting, refusing to obey rules, that does not meet, in most cases, meet the level of imminent danger. Imminent danger is danger where someone is going to be harmed irreparably in the next few seconds to minutes. It's not something that might happen next week or tomorrow. This behavior should be addressed in the treatment plans, and this should happen in both behavioral health and med-surg settings. So it's really important. That's why debriefing is so important, to drill down on this, and why staff should feel safe in talking about it, because often staff will prematurely act in calling for a restraint because they don't know what is imminent danger, and they think they're doing what they're supposed to do. So this is an issue that often takes a great deal of discussion and training. Next slide. Note on language. Next slide. I'm going to go through these really fast. It is really important that we watch our language. We have a propensity to use dehumanizing and labeling language. Target populations, line staff, in the trenches, takedown, aggression control, handling, non-compliant, manipulative, attention-seeking, needy. We call people by their diagnosis, which is incredibly disrespectful. Next slide. It is really important to pay attention to how we talk about the people we serve because they hear us. And so calling people needy, of course, the people in care have needs. And also we just took away their ability to meet their own needs. So of course, they're going to be asking us to meet their needs for them because they don't have any power to do that anymore. They're also sometimes going to be really scared. And so they're going to be what we call attention seeking, and they're going to want to be around staff. That's called survival. And that's called probably what I would do. Next slide. Person first language is the chosen language to use for recovery-oriented systems of care. It's respectful, it's person-centered, and it's based on how we speak about something is highly indicative on how we value and treat it. Next slide. Promotes the use of the words like individual, consumer, and basically uses their names instead of talking about people as patient, 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 client, 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 resident, inmate, whatever. And it never uses language like the mentally ill, which basically makes a person their diagnosis. Next slide. Next slide. Next slide. Policy and procedures have to stress the avoidance of trauma and re-traumatization for both staff and clients. And staff must feel like they can become change agents, and they need to have courage to do that because often some of your colleagues will not share this vision. So you need to have the courage to move forward anyway. Next slide. Effective leaders find staff champions. Any one of you could be a staff champion and really work with your leadership team to help make this culture change occur. Effective leaders put in place practices that provide staff with prevention tools and skills to use them. And we ask the people we serve, how does this policy feel to you? How are you experiencing your treatment here? Not just at the end of their stay, but throughout. Next slide. Effective leaders create opportunities to routinely hear staff concerns, preferably not with their supervisor around. Informal, no management discussions with direct care staff. Sometimes people set up kind of a brown bag lunch with the CEO or the COO, just with direct care staff, and they just kind of randomly select maybe 5 to 7 people that come have lunch with the CEO or the COO, where staff feel really safe to just talk about what it feels like to work in this organization. Town hall meetings, suggestion boxes, etc. Next slide. Using data. Next slide. Using data is the second core strategy. And basically what I just want you to remember about this is that every single one of you should know how much seclusion and restraint you're using, what your injury rates are, and how much force medication your unit is using. And it can be by unit. You don't necessarily need to know the entire hospital, but you should have a very good knowledge about your baseline of use of seclusion and restraint. Are you getting better? Are you doing worse? Do you have an outlier, a patient that came in that you didn't know very well, and it took you a while to get medications, and it took you a while to get to know them, and so you had to put hands on a number of times. Make sure that everybody knows that you were doing great, and you only had 2 restraint events last month, and now you've had 16, but 14 of those was Johnny, because that's really important for people to know. That's a different picture of data. Than going from 2 to 16 and it's 16 different people. So you want to create a baseline, you want to set goals as 100% reduction, and you want to look at multiple variables that go into the use of seclusion and restraint. Next slide. You want to look at unit day, shift, time of day these events are happening, who the actual patient is, when their day of admission was, because that will inform you if most of your events happening early. Or are they happening when the person's been there a really long time and that you can't find a discharge and they're bored to death? You want to look at the attending physician, the pattern of staff involved in events, number of grievances that your unit is getting. What are the precipitating events? And saying that not documenting precipitating events, like acting like the person just exploded, is not helpful for anyone. Next slide. You want to use that data to monitor the progress that you're making, discover new best practices, identify staff that are particularly good at seclusion and restraint, de-escalation, identify your units that are going to need more help. Sometimes organizations are big enough that they can create healthy competition between units. We did that in Florida. And Pennsylvania is widely known for doing that. Next slide. Next slide. So effective leaders also recognize their excellent employees. They recognize best practices and they reward them. They talk about them. They talk about the staff by name. They talk about and document near misses and what worked. And that knowledge is transferred and sustained, starting with report, shift report, all the way into policies and procedures and practices. Next slide. Next slide. Effective leaders develop a formal plan and an approach, and it starts with a prevention umbrella, performance improvement principles, and creating an accountable team. And that means that some of you might well want to volunteer to be part of your organization, or if it's just a unit, your reduction plan team. Next slide. Next slide. So in conclusion, we're talking about that seclusion restraint reduction is primarily a form of leadership responsibility, not only direct care staff, that the leaders need to create the vision, clarify the values, develop your human technology, which is your staff, using data to inform practice, value top performers, develop an organized plan, and communicate all the time. Next slide. Dwight D. Eisenhower used a simple device to illustrate the art of leadership. He used an ordinary piece of string on a table to demonstrate how easily you could pull it in any direction. But then he said, try and push it. It won't go anywhere. It's just that way when it comes to people. Thank you very much. And I'm turning back over to Beth.
Wow, thank you, Kevin. And did I tell you all at the very beginning that Kevin like aces leadership? I mean, did she just ace that or what? I've had the gift of, Kevin has actually ran at least 3 psychiatric hospitals that I know of. And I've worked with her in 2 of those. And yes, we will have, as Dana said, more questions for time at the end. And I have seen her actually be exemplary in each of those areas that she covered. She quickly knew the names of almost every person served. She knew the names of every staff. She just was present in the biggest way I've ever seen a leader be present. So thank you so much, Kevin. I've only heard that about 65 times, and each time I feel like I learned something from you. So anyway, this next module is a basic and very foundational module. There are thousands of articles and there's thousands of training programs on trauma. But this module sets a necessary foundation going back to the early research on brain science. And it's really one of those, you got to keep building on things. And this is one of those building blocks that we use. So if you go to the next slide, please, Dana. So Dr. Bruce Perry, I wish I could see you all. You could tell me how many of you have seen him. He actually has a great website that you could download tons of really interesting videos. And even though they're very child focused, they're very appropriate for numerous different adults, adolescents. They're appropriate for numerous types of programs. So he hails from Texas now. He was raised in North Dakota, and he's one of those international gurus. About 8 years ago, he was charging $15,000 a day. So he's really expensive. So just go to his website and get his freebies. But what he shares is, without understanding the basic principles of how the brain develops and changes, we cannot expect to design and implement effective interventions. And Kevin mentioned this earlier in her first presentation, is that trauma-informed care has exploded. Now we know that we have to look at things differently because of how the brain functions. So this understanding of brain functioning is critical for understanding and implementing what Brenna asked about. What are these tools? What are the things we're going to be doing? And basically, folks, I mean, I know you probably are saying, gosh, she looks about 25, but I've been in this field for probably 70 years. And so what I'm telling you is that trauma-informed care is like riding a bicycle. When you're 5, 6, 7, 8, or 4, when you learn to ride that two-wheel bicycle, you know, you could be 50, 60, or 70, haven't ridden in 30 years, and you can still ride the bicycle. Trauma-informed care is just like that. Once you get it, you continue to know that this is how we do it. So next slide. So we're going to be talking about in this section the neurobiological and psychological effects of trauma and the relationship between trauma and restraint and seclusion. And Dr. Glenn Sachs, who was from Boston University Medical Center, then went on to Harvard, then New York University, he actually set a lot of the foundation of this particular module. And he's done a lion's share of work in this area about brain science and trauma. And very early on, when he was running actually a residential program, he shared that this initiative about preventing and eliminating, which is what he did, restraint and seclusion, boils down to morality. And he gave an example. He says, for instance, when you're serving a young woman who has discontrol problems because of her previous abuse, and we feel that when she is actually having these problems because of her previous abuse and subsequent trauma, and staff think, oh, you know, I got to raise my voice to get her attention, or I got to be really firm and coercive, or, you know, and even do the hands-on, that actually what Dr. Glenn Sachs said, this is not ethical. It's against the Hippocratic Oath. And when we restrain traumatized individuals, we actually do more harm as opposed to no harm. And in fact, this is some data from his program. This next slide, when he was working on this, and it took a while to get there, as you see. This slide is very similar to the one I showed you in assumptions on what the experience was with the Virginia program, UCARU, is that because of his clinical and ethical reasons, you know, he was committed, same with UCARU, most often the same with anybody who goes into this work to prevent, reduce, and then eventually focus on elimination, is that, you know, he thought it was unethical. And what he found, you can see that they're looking here not only at the episodes, but they're looking at the youth injuries and the staff injuries, but the staff injuries go down as the youth injuries go down too. So it's extremely, his work was very foundational for what we're talking about. So next slide. And that kind of leads us to a way of looking at what we call pathways. We used to have like a picture of a little girl with a balloon walking down a path and talk about how, you know, adults clear the paths for children to grow up to be resilient and strong. And that we as staff in any kind of program we're in, we clear the paths for the children, the adolescents, the adults that we're serving, the families that we're serving, so they can walk to those futures also. And so this particular study shows another way of looking at pathways. And it's a summary of research of children who were in a hospital for severe burns. So they were in an actual hospital because of on burn units. And the first point on the graph actually represents their degree of post-traumatic stress disorder at admission. They use the post-traumatic stress disorder index scale. And the second point, the end point, depicts 3 months after admission. And this is kind of our first real learning about trauma. It exemplifies that every single person, adult, child, walks different pathways to trauma and how they're going to respond to trauma. As you see, some of the children had very little to no trauma at admission, and it actually, they didn't develop symptoms. Other children had high rates, it went down. Some had lower rates, it went up. So one of the most important aspects of knowledge relative to understanding the impact of traumatic events is that it's individualized. each person, based on their own history, their own neurobiological and physiological and psychological makeup, is going to respond differently. I'm waiting to see I don't know if anybody here has seen the 20-year follow-up from 9/11 in New York City, but the 10-year follow-up study on children was pretty interesting in terms of those children who were traumatized because of what happened on 9/11. And what they found is that those children for which this was the first traumatic event and they received the resources and the supports and the treatment to move forward, what they actually found is that these children recovered quickly. And the more traumatic events a child had had, the less likely actually it was for them to recover quickly and recover completely. So the slide that Dana just put up here is actually another study, and we have what we call the end point of trauma. This is from a famous study by a man named Michael DeBalis and his colleagues at Duke University in North Carolina, where Kevin's from. And it was published way back in 1999. And what they studied were the brains of children who were abused. So you can see who has kind of the smaller white line, I guess on your left as you're looking at it, are those 11-year-old maltreated male with chronic PTSD, and then the healthy, no maltreatment on the right side. So using this MRI technology, they actually identified damage to the children who had of the brain, to the children who had been exposed to trauma, and that the brains of the children who had been abused actually were compromised. You can see the intracranial, the cerebral volumes were actually 7 to 8% smaller in the subjects with PTSD in comparison to those who had no history of trauma. And that's kind of the loss of that prefrontal cortex and the cerebral cortex, which are really the CEO functions of the brain. So if you think about what this means, and many of the people you serve have abuse in their childhoods and into their adult lives, they likely also have brains that have been impacted by this abuse. And this is what we'll be talking about today, how this abuse, these traumatic events can actually affect everyday interactions. They can affect learning of the people we serve when they're with us and actually for the rest of their lives. So the pathway of post-traumatic stress is really filled with tragedy, and we want to get our heads about what this means. And as you through the field of traumatic stress, we're going to take a developmental perspective of this. And so this Neurons to Neighborhood report, which is on the slide in front of us, it's a small, actually, pamphlet. It's a report, but it describes the science of how our brains developed and how we become functioning and successful adults. So if I could see you all wave, I don't know if you can go back to that. If you can, how many of you are functioning and successful adults? I can't see waves, but anyway, I guess all of you all are. So that means that, that you can, you pay, how many of you pay taxes? How many of you pay for rent or something, or a mortgage? Or how many of you have to pay for transportation? And then how many of you, when you get really upset about something, you don't throw a cup across the room? Okay, well, that means you're a successful adult. That's really a broad perspective, right? So this really helps get to how do we become successful. So the next slide, please. We're going to just do a little bit of, we're going to go back to that Neurons to Neighborhood report and cover maybe about 6 of the 12 little hallmarks in that report. But just a quick look at the prevalence of trauma. There's prevalence data in so many places, but they provide these rates for both children and adults, and both those we serve. And remember, it's not only about those we serve, it's also about us. Massachusetts did a point-in-time study a number of years ago in their psychiatric hospitals and found that actually 25% of staff at that 25% of staff actually had PTSD. So look at the rates of children, quite high. Look at 92% of incarcerated girls, and how many adolescents had been victims of serious physical assault. Go to the next slide, please. And we're going to have a few more slides about this tomorrow on trauma-informed care. But look at the PTSD overall in the United States. Look at how many men and what percentage of women are going to report one traumatic event. And many of those, which I think is very, very concerning, 80% of those with PTSD are going to suffer from other psychiatric disorders too. And for at least a third, it's going to be persistent condition experienced for years. Next slide. What we know about the impact of adult PTSD is that when you think about childhood trauma compared to adult onset trauma, there's a greater probability when there's been childhood trauma of developing these psychiatric disorders, anxiety disorders, PTSD throughout their lifetime. So it's believed to have this long-term impact, just like that very first foundational study talked about, on different regions of their brain and how they actually process information. So next slide, please. And in terms specifically adults, it's been studied less, but what we know is that there's 4 main risk factors for PTSD in adults: a pre-existing psychiatric disorder, family history of disorders, that childhood trauma, and being female. So we know that late onset PTSD is under-recognized and under-treated, and there's so many more challenges, not only in there psychologically, but also in physical health symptoms later in life. And we'll review, as I said, more of that tomorrow. So next slide, please. So what we want to do is we want to consider, and this goes back again to Brenna's question, what do we do? So what we want to do is account for, to address traumatic stress, that the individual we are serving has a dysregulated emotional nervous system, okay? And the second is that their social environment that's supposed to contain that dysregulation, it could be their family, their school, their community, their work, or whatever environment that they were in was not able to contain that, and they are with us. So both principles are very important. When you have traumatic stress, there's something going on internally that the person is not able to contain. The nervous system is essentially, as it says, dysregulated. So they're not able to control their emotions or their behaviors. And so we're going to create these social environments where we can, in fact, focus on that. So let's go to the next slide. And this is from that Neurons to Neighborhood report. And basically, it shares that all of us unfold along individual pathways from the moment we're born. How many of you have children, like say, that are over the age of 12? I can't see you, but I'm sure some of you raised your hands. And when you think about like that child now at 13 or 15 or 17 or 19 or 22, is it exactly that unfolding go exactly how you envisioned it when that child was born? No. And it's especially going to be different when any kind of trauma occurs in a person's life. That trajectory of that life path changes. They were moving along on their path, and then there's going to be a trajectory. So the next slide, please. And this goes back again to that study on the children with burns. And as we see, it's all individualized. So that's, again, that first take home, individualized. And as Kevin shared eloquently earlier in leadership, we don't know, and sometimes we'll never know what happened to the people we serve. So we have to just assume that, and use universal precautions of trauma, that there has been something, and they've all had loss, experienced deep losses. So let's go to the next slide, please. So what's PTSD characterized by? It's often characterized by re-experiencing that event. It could be intrusive thoughts or nightmares or flashbacks. It could be avoidance and numbing. Like all of you have seen that flattening of effect, loss of interest, lack of motivation, constant avoidance of any activity or event. But what's really important to remember too is that when somebody experiences in their own internal self past traumatic event, it can lead to out of control behavior. So when you see out of control behavior, when you see a person begin to escalate, it is often because they're re-experiencing in some way something that happened to them, and they may not even be able to verbalize it. In a program in New York State, a residential program in New York State, whenever they do debriefing, they use a trauma lens, and they try to use that lens to actually find out, can we see what might have impacted this person in becoming dysregulated? Can we go back and learn from that experience? So next slide. And this is the second core concept from the Neurons to Neighborhood report. And it stresses the importance of self-regulation. So many of you have heard of Bessel van der Kolk. You know that he and Oprah Winfrey just wrote that book, What Happened to You? And he had written that very famous book about the body keeps the score. And he's amazing in this field. He's dedicated himself to it. In fact, he's so good at it that he's on my short list for my next husband. But what he has said is that if you have children of your own, the most important thing you can teach them is to self-regulate. Because if you can self-regulate, you can basically navigate life. And so what we want to focus on is supporting people in that self-regulation. And regarding traumatic stress, one of the most important concepts is what happens between what we call the transition between what we're going to call a calm state and discrete states of emergency. So next slide, please. And so these are two examples from Dr. Glenn Sax's work. And this is going to talk about kind of that transition from calm to discrete states of emergency. The first slide depicts a young man named Robert. He had been severely abused in childhood by his stepfather. He was on a psychiatric unit and he was having a good day. Everything was fine. He was in that calm, engaged state. And then he perceived, and this happened from Dr. Glenn Sachs doing a meticulous interviewing after this all happened, he perceived that a male staff member said something demeaning to him. And so what happened is he went from this calm state and self-regulation, the essence of really being able to maintain that calm and not becoming dysregulated, did not occur. He immediately lunged at the staff member that he thought he heard him say something negative about him. He ended up, so that's aggression. And then he ended up becoming very fearful when he was restrained and feeling like he was being hit again by his stepfather. And then he actually just began to disassociate. And so it was exactly how his grandfather used to talk to him, how he heard that voice of the staff, and actually in the debriefing, the staff didn't say anything demeaning, but he went from this calm, continuous state to 3 states of emergency. So the transition between calm and continuous and discrete states of emergency are essential for understanding traumatic stress and its neurobiology. Here's another example, next slide, from Dr. Glenn Sachs. It's a 12-year-old girl. She had a history of sexual abuse, but she was living at home and she was going to school in the community. She was in school that day. She was having a good day. She was actually in math class. And again, this is from Dr. Glenn Sachs' meticulous interviewing and debriefing with her after all this happened. The boy sitting next to her leaned over and said something sexually demeaning about her breast. She immediately went from this calm state, self-regulation did not occur, to this discrete sense of emergency where she was stood up and she had this intense sense of shame, and she began to walk out of the classroom. And as she walked down the hallway, she began to have this sense of re-experiencing in her mind's eye the sexual abuse, the rape that she had been through. And that was when you could actually leave the classroom, leave the school. And so she walked out of the school, she went home. She used her key to get in. She went upstairs. She went to the bathroom. And what do you think she had hidden in the bathroom? She actually had hidden a razor blade. So she began to actually disassociate, that 3rd state, and self-mutilate. Luckily, her mom was home. They got her to the hospital. But this is an example where self-regulation did not occur, that, the cornerstone of development. So it's fundamental. When you see someone with a trauma history have behavioral or emotional discontrol, this is what you are in fact are seeing. So next slide, please. All of this is actually built on what we call normal developmental principles. We're going to stay here for just a minute, Dana, on this slide. This is how we all come into the world. How many of you have children of your own at all? Any kind of children, right? So do you remember when you first brought that child home, that infant from the hospital or a birthing center, you had that baby at home, and the brand new bundle of joy. And what did you do? Anybody? You pick, and the baby starts crying, you pick the infant up after you realize he or she doesn't, or they doesn't need to do any, eating, or you don't need to change their diaper. What did you do? You rocked. You didn't rock once. You didn't rock twice. When I ask the owners, they say thousands of times you rocked. And so what we find is that in some studies is that that the world of infants, way back then, it's divided into these definable behavioral and emotional states. And that the critical task of early development is actually building smooth bridges between these states. And so that movement, and as Kevin said, we're going to get to sensory on day 4, when it happens hundreds and hundreds of times, it helps people to self-regulate. And so, but when you have people who come from maybe a traumatized family, or they've been abused, or there's neurobiological issues, they haven't learned that. And so people go from the stimulus to response that's here, and it goes very quickly. So let's go to that next slide. So we want to set up our treatment environments. So when people go from stimulus to response, that we have neuroregulatory interventions, or interventions that help people, build cognitive structures that allow choices. We have we create these social environmental interventions. This is how we want to set up these environments, so that actually what we do, next slide, please, is that we build this wedge of cognition, is that we really want to have this, that when this young girl hears this boy say something demeaning about her breast, she remembers her clinician saying not once, not twice, probably, 50 times, that because somebody says that does not mean you're going to get hurt if you're in a safe place. So we are, all of us as staff people, we're actually, we are craftspeople. And it reminds me of, I don't know if it was my 4th or my 5th husband, but his grandfather was from Russia, and he used to build these ornate pieces of furniture when he lived in Russia. He was a cabinet maker, and when he came here, the only thing he could do was get jobs in a furniture factory. And sometimes that's what it feels like, is all we're doing is enforcing rules or checking off boxes, but you're craftspeople, and your job is to really build that wedge of cognition. And to support them. We want to know that the people we serve know there's other alternatives than these discrete states of emergencies. And that goes to the 3rd development. Or if you go to the next slide, please, it goes to that 3rd developmental concept, which is that human development is shaped by an interplay. It's not just biology, or it's not just experience, it's a continuous interplay. So next slide. And this is one of those foundational slides that actually, is looking at, different parts of the brain. And if you could see here, you can see the hippocampus here and the amygdala. And I'd have you shout this out, the amygdala is responsible for fight or flight or freeze. And we're going to talk about it as fight or flight. And then the hippocampus and other areas of the brain actually apply context to the situation, and they help to kind of regulate that amygdala, and they're on both sides of the brain. So that's going to walk quickly through how the brain operates. A stimulus could come in on the next slide, please. It could be any stimulus. Say it's the boy hearing something. This is how all of our brain works within 15 milliseconds. You can't even count that slow. It goes to something called the sensory thalamus. And from there, it goes to 2 pathways. The first pathway goes very fast, again, milliseconds, maybe milliseconds, 30 milliseconds to get to the amygdala, which is that fight or flight. But then milliseconds later, it goes to the hippocampus and the cortex, which kind of course, they dampen the amygdala. They give context to the situation. It's where memory comes into play. And so this is how our brain operates. And then we have, next slide, please, a response. But what happens, if you go to the next slide, is that when we have people who have had traumatic events, go to the next slide, please. You see that, into the next one too, please, that when people have histories of trauma, that, as I showed in one of those first slides, is the cortex and hippocampus, which, the CEO function of the brain that regulate the amygdala, have actually dampened. They're not working as effectively. And the next slide, please, the amygdala actually, go to the next slide again. Sorry, go back one. The amygdala actually, in one of our slides, shows that it actually is compromised. And so that's where we want to build in those neuroregulatory interventions. That's where we want to build in those social environmental interventions. So we want to diminish signals that may cause distress. We want to work to enhance emotional processing. We need to create environments where people do not react extremely. And so to the slide then that you had seen, next one here, is that this is from Scott Rauch, actually with Dr. Bessel van der Kolk, and they used a PET scan of people who had traumatic stress, post-traumatic stress disorder, and then they interviewed them while they were using this PET scan. And what they found is that when they were remembering the trauma, when people were remembering their trauma, that their amygdala started firing, which is responsible for fight or flight. But he also found that if you look at this bottom, I think it's your right, the Broca's area of the brain, it actually, which is responsible for speech, I would ask you that if we were in the chair, it actually began to look like it was shrinking. It actually became less robust. And so you have probably heard the term speechless terror. So it's true that when people are not able to speak sometimes during stress, so when we ask them to tell us about it, sometimes they're not able to. And that's why we have to get some of those sensory pieces. Now I want to talk to you about a rat study. Sometimes if the next slide, rats, they're born, then in this particular laboratory, after they're stopped nursing, they put in with a cage with another rat, and just like young children, they play. They have dorsal contacts, they have pin contacts. This is from a book by Jacques Ponscopt. He's a neuroscientist and he studies rats at play. We'd have four of you come up and kind of model this if we could, but think about it. This is how they play. And they've always lived in this laboratory. Their parents lived, their grandparents, their great-grandparents lived in the laboratory. So what happens is that he then puts in, next slide, what he calls a minimal fear stimulus. And that is one cat hair. They've never seen a cat, grandparents, great-grandparents, nobody's ever seen a cat. But so they're playing all day, but when they put the cat hair in the cage, one cat hair in the cage, you know what happens? The rats stop playing. Okay, their cage is in there, the rat hair is in the cage for 24 hours and they don't play for 24 hours. But what's even scarier, when they take the cat hair out, they never play the same amount again. And what Dr. Glenn Sachs shares, if you have restraint or seclusion in your program, you're flooding it with cat hairs. And the ability of the people we serve being able to trust us, to feel safe actually goes down. So there's so much work we need to do in this. So the next slide, please. We can go to the next one, please. So basically all this neuroscience, you know what it gets to? It gets to the importance of relationships, that they're the building blocks of healthy development. And Kevin talked about almost like if you're having a bad day, stay home. You know, we need you to be so present. Neuroscience, the first step to really healing is human relationships. And so what we want to do is we want to make sure that every single person in your school, in your unit, in your program is really focused on this kindness and this caring. And when somebody does have a problem or it gets dysregulated, we want to ask, what did we miss? What might we have done differently? And we also want to say, I'm sorry this happened. What can we do differently in the future so that we're really setting this as the foundation of everything that we do related to trauma-informed care. And so to the next slide, please. We're going to skip this one and the next one and the next one, but you can go back to these. Dana has sent you the slides. So some of these are important, but basically it goes to interesting is this whole Neurons to Neighborhood, well-researched pamphlet is summarizing on the research. It says not only after relationships, but you want children and of course adults to be an active participant in their own development, that people do better when they can make choices. So the reason your success is not only because you had somebody who cared about you, but you also had choices. Somebody gave you choices. You learned to make those choices. And so what we want to do is consider all of this. If we go to the next slide, please. And then the next one. And because what this Neurons to Neighborhood also shows us is that the course of development can be altered. That when we use effective interventions, when we move towards that evidence base, we actually change the balance between risk and protection. We're actually building in with those people we serve strength and resiliency and understanding and tools that they can use. Anything we use in the hospital, the residential program, in the school, they want to be able to use at home too, or where they live, so that we're giving them those tools to alter that, what's happened in their lives. And so next slide, we know from the research, say on traumatic brain injury, that improvements can be achieved. And this slide really summarizes some of those basic best practices in healing from and recovering from trauma. And so these are areas to go back to think about. And to that next slide is that you as staff can create these social environments. You can create this support to support the people you serve in terms of that internal learning, that internal self-regulation. And when we build in these more strength-based approaches and trauma-informed care, we actually prevent extreme behavior, and we build each person's capacity to walk the path toward health and adaptation. So we really clear that path for the people we serve. So teach your own staff, your colleagues about the pathways of trauma and their responsibility for clearing those paths with sensitivity, understanding about what traumatic stress is and what it means. And I'd like to end this particular module with also a quote by Dr. Martin Luther King. And what he said was, cowardice asked the question, is it safe? Expediency asked the question, is it politic? Vanity asked the question, is it popular? But conscience asked the question, is it right? And there comes a time when we must take a position that's maybe not safe, maybe not politic, maybe not popular, but we must take it because it's right. And so we're going to move into questions now. And I don't know, Kevin, if we had any questions that came up on the chat, or if you saw any of those. Okay, so anybody has any questions? Comments? Brenna and Angela asked questions before, and we've already sent each of them $1,000 gift certificate. So, you might want to think about it. Any feedback, anybody?
The other thing, guys, too, is sometimes you'll think of questions afterwards. So just jot them down, because of course there's 3 more sessions. And also I just wanted to make you guys all aware, which I didn't even know, I just figured it out, is that you have to register for each session, like separately. And because I think that's how they keep track on who's doing what and the CEUs and stuff like that. So please know that there's another session tomorrow and then 2 next week. And they're all at the same time, and they're all just for 3 hours. So we hope that we'll see you. And if you do think of some questions in between today and tomorrow that you won't forget, then you can ask them.
Right. And thank you for that joke, Brenna. Comments? Okay. Before you go on to your next event or activity of your day, remember you have to move. When you do training in Canada, they make everybody get up and move around regularly so that you can stay self-regulated. Please fill out the survey and feedback. Even if you don't get CEUs, you can do it just to document your attendance. So
And you also get I think you'll get a certificate of some kind if you want that.
Yeah, if you fill that out. So we appreciate you being here. Wish we could see you. We know that you're absolutely wonderful and waiting to see you again tomorrow then, or to know that you're there tomorrow.